Well, good morning. I have to say it's certainly a great honor and privilege to speak to such an esteemed group, and I've learned so much from surgeons throughout my training. At MGH, I learned a tremendous amount from many of your colleagues, John Wayne, Cam Wright, and the late Dr. Grillo, among others. And now to have the opportunity to learn from Mac on a weekly and even daily basis has been terrific. What I hope to do this morning is to share with you a little bit of my insights into lung cancer screening from an imaging perspective. And I look forward to doing that. Well, lung cancer, as I don't need to tell this group, certainly preaching to the choir here, a leading cause of cancer death worldwide. And in fact, last year alone, over 200,000 new cases and nearly as many deaths. And as you know, if we look at all people who present to you with lung cancer, only about 15% are going to survive. This radiograph of a patient with symptomatic lung cancer, I'm sure, is all too familiar to each of you in the audience. And about 70% of patients today still present with symptoms at the time of their lung cancer diagnosis. This individual went on to have a CT showing not only extensive vertebral body destruction, but also a lot of chest wall invasion. Well, as much as that's familiar to each of us here, I think this is becoming increasingly familiar to all of us. The small, incidentally detected lung cancer, whether it be on a CT pulmonary angiogram for the person who comes to the ED with chest pain, or perhaps a chest CT performed for other purposes. I would just be curious to get just a show of hands. Your last lung cancer case, how many people here was your last lung cancer case for an incidentally detected lung nodule, either in screening or on a routine CT? That's really, I think, is a pretty impressive show of hands. I would say it was about a third of the group. So these stage 1 lesions, you know, have a better survival. Stage 1A, numbers vary, but greater than 85% in most series. And I think this has really generated a lot of renewed interest in screening. What I'm going to do this morning is talk very briefly about a few basic concepts of screening, and then talk about the past, the present, with some update on ongoing trials and what I think will be the future of screening. Well, I'm showing a mammogram here because it really is probably the most widespread form of imaging-based screening. And certainly any test you use would be the application to detect a particular disease in someone who's asymptomatic and at risk. An effective test certainly needs to detect the disease before clinical symptoms. Earlier treatment must be more effective than later treatment. And certainly the benefits of early treatment need to outweigh the overall harm of screening. When we look at lung cancer, certainly a lot of things make sense for screening. We have a very large population of people that we can identify are at risk because they're either present or former smokers. We know the preclinical phase is detectable, and we know that early disease, surgical resection, is potentially curable. Now, the issue with any type of screening assessment is that there are going to be biases that we want to avoid. Lead time bias, length time bias, and overdiagnosis. And really the best way to avoid those type of biases when we're trying to study a screening test is to look at lung cancer specific mortality. And that's widely been held as a gold standard for screening for whatever disease you're looking for. Well, unfortunately in the past, as I'm sure each of you is familiar, the randomized control trials that were looking at things like chest radiography and sputum really showed no reduction in lung cancer mortality. And I think the trial that's most familiar and has been certainly cited the most in the literature is the Mayo Lung Project, which included randomizing to control versus a study group. And a lot of difficulties in that study in terms of both the control and study group got some type of surveillance, and there was a lot of contamination. That being said, there was early a lot of hope for that. More cancers detected in the study group, higher resectability rate, and a 5-year survival benefit. But unfortunately, at the end of the trial and subsequently thereafter, 15 years after completion, there's been no mortality benefit. Some have argued that the improved resectability, lower stage, and better survival rate couldn't be explained simply by lead time or overdiagnosis, and that the chest X-ray deserves another round of appraisal. Well, what I'd like to do now is leave the past behind us and really look at the present and future. And I think that when we talk about the present, although there are certainly a wide variety of emerging lung cancer screening techniques, by far and away the one that we have the most information about is low-dose helical CT. The one that I think we're most hopeful for, the holy grail, so to speak, is at the bottom, biomarkers. I'm going to focus today on lung cancer screening with CT. So here we are in the present. We've got a renewed interest in lung cancer screening, not only because of the increased utilization of CT and the fact that we're detecting these smaller cancers, but as happens, every once in a while we'll get a celebrity of some sort, someone well-known with lung cancer, that brings this disease back to the attention of the American people. The sad news is that these spikes of public awareness seem to be relatively short-lived because there are really so few survivors of lung cancer. And I'm absolutely delighted to see that you have a survivor of lung cancer in your program here today. The other piece of the present is that, unfortunately, despite all of this renewed interest about screening, we really have no recommendation to screen. Well, let's talk a little bit about what's brought us to this level of interest in screening, and that really started in the early 1990s. Investigators both in New York and Japan simultaneously began screening for lung cancer using low-dose CT. And in these particular trials, they had a control group. They didn't have a control group, but they did compare to radiography within the same group. So they were able to, in the same population, compare CT and chest X-ray, but there was no one who didn't have a screening. So these were the trials, and it was very interesting that the results were quite similar. And in fact, the Helical group, the LCAP study, had 1,000 people screened, and you can see the Japanese trials were larger. The lung cancer prevalence rates differed, but that really had mostly to do with the entry criteria for screening. And then finally, the big news was that a large percentage of the cases that were detected were stage 1 cancers. And that was really a paradigm shift in how we thought about detecting lung cancer. The LCAP study is perhaps the best known, and they screened 1,000 participants initially who were over 60 years of age, more than 10 pack years of smoking, and again, everyone got both a CT and a chest radiograph. They used what at the time was a very standard approach of a very close surveillance for any non-calcified nodule. So patients or participants could get up to 4 follow-up CT scans over a 2-year period. Anything that was over 5 millimeters either got followed up or biopsied, and anything that was over 10 millimeters and not calcified was biopsied. The results were really impressive. There was about a 23% positive rate at baseline screening, but using their criteria for follow-up and biopsy, only 28 nodules were biopsied. Nearly all of the biopsied nodules were malignant. Almost all of those were resectable, and 81% were stage 1A. And there was also a very high percentage of adenocarcinomas, which represented 93% of the cancers. Well, they also reported their 1-year incidence scan. You have to remember that certainly at a baseline scan when you're doing a CT, you're going to get a lot of positive results. But the hope would be when you have a comparison for everybody and they come back in a year, you'll have a much lower positive or false positive rate. So at 1 year, there were 5% newer growing nodules. They had a 1% detection rate of lung cancer. And again, 83% of the cancers were the very early stage of 1A. Well, concurrent with those other trials, as they were sort of tapering off, the Mayo Clinic was just getting started, and they had 1,500 patients in a trial that looked at CT screening and sputum cytology in over 1,500 participants who were over 50 years of age with over a 20-pack year smoking history. Now, their study was a little bit different in that they used a higher level of technology, the multi-slice scanners with thinner slices, so they're going to have a higher detection rate of lung nodules. They were also sort of on the edge of a granulomatous belt, and what they found was that among their 1,500 participants, there were nearly 3,400 lung nodules, and that represented 74% of participants had one or more nodules. Of those participants, there were a total of 68 lung cancers, 31 at baseline,